My name is Jang Yoon. I'm a neurosurgeon at Penn. I'm the director of the MIS spine surgery. I also co-direct the fellowship. I do endoscopic spine surgery. I got into it during my fellowship with Mike Wang, got exposed to uniportal. And during my practice, I was kind of frustrated with the limitations of uniportal because there's a very limited pathology you can treat. Mostly discectomies and decompressions. But when it's time to put in a cage or do a true lumbar fusion, there's a lot of limitations of working everything through one single channel. So I began to sort of expand my horizon, and there is a whole group of surgeons overseas, mainly in Korea, who really honed this technology. So him and I connected, and afterwards I traveled to Korea, watched one of the master surgeons perform the TLIF using a two-port system, dual portal. And I came back and then I just kind of ran with it. It really truly represents, I think, a true leap in the way we perform the TLIF. I think the TLIF has been done open, tubular, and it's been pretty stagnant for 20 years. And hasn't really made a whole lot of changes. But what dual portal really allows is to perform the TLIF in a way that's traditionally done. So meaning doing a decompression, disc prep, all same way. You decompress the nerve, do a complete discectomy to end. And then the cage insertion that happens is almost like an A-lift footprint through the small corridor. And I was really blown away for the ability to do that complete decompression and do a fusion through a tiny incision. And I saw a big difference in my patients. They're getting up faster. I had a patient that went home less than 12 hours in the hospital, which was unfathomable. I mean, most patients that get TLIF on average stay 3 to 5 days, maybe a week in the hospital with a lot of narcotic medications. They're not mobilizing, so they get complications. The wound complication is a big deal. Just haven't seen any of that with the dual portal technique. So it achieves the same level of bony work, nerve decompression, and orthodesis, and also ability to correct the alignment. I think combining all those things, it really sticks to the same surgical principle that we are taught as a spine surgeon, and you're able to achieve all of that, and even more. So I'm really sold on this technology. You know, dualX is, I think, the only cage that expands in the width first, so that it actually creates the footprint before it lifts up. So that's really important because most of the expandable cages in the market, they expand bidirectional or unidirectional. The problem that happens when you unidirectionally or bidirectionally expand is that there may be some weak points in the end plates, and they may not be noticeable during the surgery. And you're applying all that, a lot of pounds of force against the end plate, and then they may break the end plate because you maybe haven't done enough discectomies. And so if you imagine that you're applying all that force through a very, very narrow footprint, and that's tremendous amount of force in that one small area. What the dualX represents is that it spreads all that lifting of the forces over a very wide footprint. So it first expands horizontally, and then it goes vertically. And it's also very unique in that it has up to 15 degrees of lordosis, which is that's not available in other expandable cages. So really, you're able to insert. It inserts just like a bullet cage. Dimensions are very similar, and then once it's inserted, then you can expand horizontally first. Then what you're doing then is setting up for your vertical expansion, so that all that pounds of force is not concentrated in a small area, but is spread over entire end plate. Then you're really truly lifting up the vertebral body in the lordosis that you want. There isn't any other cages like that in the market. So Slim, first I think is smaller and it's much easier to handle. So you don't have to retract on the nerve as much. You may not have to do as much bony opening to get this in. It truly feels like you're inserting a typical bullet cage when it goes in. So it's much less bony work, less time to get to the insertion stage. And then once the cage is in, it expands inside the disc space just almost to the point where it looks very similar to the original design of the dualX. In addition, you don't have to go up as high in the height to get the lordosis. So you get up to 15 degrees with the slim. So what it represents is a easier to insert cage that has just as enough of the width of a footprint. Also, it has a 15-degree lordosis. So it really, I think it's a sort of an evolution. It's a second evolution of the original cage, and I really think that it has allowed me to perform the T-lift very efficiently. So now, I think we talked about doing a transfacet T-lift, where I don't have to expose the exiting nerve root and traversing nerve root. I can create a small window into the facet joint and then insert this cage, and then I go back and decompress the nerve afterwards. So that really transformed the way I perform T-lift. So when I first began, 2 years ago, we went through a big learning curve on how to do this safely and do this efficiently. And I think after about 5-10 cases, became quite comfortable. So for me, when I get started, going back to when I used to do it open or do the tubes, T-lift has always been a very difficult procedure to master, because you're working around the nerve in both directions, exiting and traversing. You have a facet joint. You're trying to visualize these really fine structures with not a lot of light, because the microscope, the lighting is outside the body. So when it came to endoscopic, you're visualizing everything in 100 times magnifications, and then the visualization was just unparalleled compared to tubular techniques or open technique. So the visualization was so much better. And then secondly, with the slim, marrying it with the dual portal, allowed me to really tailor the facetectomy, so I don't have to open up as much bone. What that means is that the surgery goes faster. I don't have to expose the nerves that when you expose the nerve, you actually put them at risk of injury. And with the Slim X, you're able to insert the cage without exposing all that nerve, putting them at risk, and still get the proper expansion and lordosis, and then you can come back and decompress those nerves at the end. So in a way that really made my surgery faster, because I don't have to spend as much time decompressing, creating the window. And then secondly, I still get the same sort of correction that I want. And then thirdly, it made the surgery safer. So the 4-5, I think, is always the most difficult level to do inner body, whether you do it A-lift, laterals, or T-lift. T-lift is 4-5, it's got lordosis angle, not the easiest level to tackle. And so I've been a huge proponent of lateral techniques or ATP techniques in the past. I still utilize it to time. The reason I moved into the lateral space at L4-5 is because I wasn't happy with the cage, with the T-lift cage at 4-5, because at 4-5 there's a lot of biomechanical stress, hard place to achieve arthrodesis, because the cages that you insert traditionally are so small, such a small footprint, unless you put in a banana cage, but even banana cage have a very small width. It may have a big length, but it has a very small front to back width. So I was never happy with any of the cages that are in the market. So now with the dualX and the slim cage, really shifted the way I treat L4-5. Compared to the laterals, I can put in the cage that nearly matches the lateral size. Also, it nearly matches the A-lift, the cages, when I use the dualX, the T-lift. So in my practice, really has a way I treat the L4-5 level and the other levels. The limitation that I was feeling with traditional cages, now I've converted to doing a T-lift. So I do a lot more T-lift compared to A-lift and laterals. What I like the most is that it allows a surgeon to perform the most minimally invasive surgery that you can possibly perform at this stage in our technology. What that means is that you don't have to make as much of a big incision. You don't have to do as much bony work to achieve the same level of, same principles that are required to do a proper TLIF, meaning a nerve decompression, doing a thorough discectomy, doing a orthodesis, putting the cage that matches the lordosis of the natural lordosis at L4-5 and other levels. So I think the dualX is, to me, it represents sort of the next generation, next iteration in the TLIF. And it truly is 10 times better than the prior generation of the cages. It's actually a pretty recent case. There was someone that I actually treated, someone who underwent L4 to S1 decompression done, and I did it open. And this patient did well. Initially, he had a mostly neurogenic claudication, so I did a decompression for him about 2 years ago. And then the patient came back and was like, okay, he's hurting a lot. I re-imaged him. He developed some, slip around those levels. He had a lot of facet arthropathy. So, and then those at those two levels, L4-5 and L5-S1. So, and he was a pretty big guy, high crest. So, what are the options now to do a two-level fusion? ALIF, well, ALIF is hard on this guy because he's got big belly. Getting down to the 5-1 will be difficult, but 4-5 will be very difficult. Lateral is not a good option. Well, you can do a lateral at 5-1. And if I do a 4-5, 5-1 ALIF, 4-5 ALIF, lateral, then do a screws in the back, that's 3-stage surgery. So there, I decided to treat him all through the posterior approach, but dualX. So I used a slim. So I did a 4-5 and 5-1 interbody fusion using with the slim, and then fused him from the back. So this is a revision surgery, interbody fusion, and a two-level fusion. And I performed the surgery, and he left the next day. And he walked up from the surgery. He's like, "Doc, I feel like a new guy." And he had an Eagles jersey on, and he gave me a thumbs up and then left the next day. So I just had, I don't think that would have been possible had I had done open TLIF or ALIF or a lateral. Any of those options, I would not have been able to treat him and discharge him the next day. Now, I think a long-term outcome, I think it's going to be, it's going to be also great too, because I put in a very biomechanically sound construct, restore all of his alignment, and then perform a screws and rods, and then so posterolaterally also fused him. So I think not only is it a great short-term outcome, the long-term outcome, I'm very hopeful that he'll do really well. I've seen a lot of expandable cages in the market. I haven't personally adopted them because I wasn't too excited about sort of how it works. And truly, I think the dualX it gets me excited because it's really thought out, it's really thoughtful cage. The way it expands, the way it restores the alignment, weight is locked in, weight is inserted. Everything is from the incision to the insertion to the closure. Everything is very thought out, thoughtfully, and it's designed very, very thoughtfully from the start to the end. So, so I'm very excited about this cage, and obviously I've been doing a lot more interbody fusions, and the patients do well, and I think I'm excited about sort of the long-term outcomes of these patients, and then sort of the next generation. I'm excited for the next generation of the dualX.